Good afternoon, everybody. Welcome to the first Key Population webinar. It's hosted by South to South Learning Network. We would like to extend a warm welcome to all of you and are very, very happy that you could join this webinar. For those who do not know, the South to South Learning Network supports the Global HIV Prevention Coalition to strengthen country HIV prevention programs via shared learning and networking. It's in 10 African countries. It is coordinated by Genesis Analytics and the University of Manitoba and supports the country programs to identify programmatic gaps and priorities for HIV prevention response, and also to build social capital for joint problem solving. The initiative is funded by Bill and Melinda Gates Foundation. As we all know, key populations, sex workers, men who have sex with men, transgender people who inject drugs, and people in prison settings are disproportionately affected by HIV in all epidemic contexts. Globally, KP and their sexual partners account for 62% of new HIV infections. And it makes HIV prevention efforts tailored for this population very, very essential for epidemic control. Though there are several structural barriers, including criminalization of key populations in many countries, some countries in Africa have shown that it's possible to achieve high coverage of estimated key populations with comprehensive programming. Our webinar today is titled Building a Strong Foundation for Scaling Up Impactful Programs with Key Populations. We have 3 accomplished presenters. Each presenter will present for around 10 minutes, and it will be followed by a discussion or a question and answer session for another 10 minutes. Please feel free to write your questions on the chat box, which we will read out for the presenter to respond to. Otherwise, you can also raise your hand using the raise hand button and ask your questions directly. Our first presenter today is Dr. Richard Steen. Richard has worked as a public health clinician and researcher in designing, implementing, and evaluating interventions and operations research in areas of STI control and HIV prevention for more than 20 years now. He has worked in several Asian and African countries. Richard led the development of the Trusted Access Platform tool for the Global Prevention Coalition, which he'll be sharing today. He currently is associated with South to South Learning Network and also with the UNAIDS TSM. He's affiliated with the Janna Institute for Community-Led Structural Interventions, hosted by DMSC and Ashodaya Academy, 2 community-led collectives that have led the way in KP-led programming. I've known Richard for many years now, and I've always looked up to him for technical and professional guidance. We are very privileged to have you today, Richard. Over to you for your presentation.
Thank you, Pari. Okay, this is the first slide. Yes, okay, thank you. So hello, everyone. So Trusted Access Platforms is the topic of this presentation. The concept is nothing new. Trusted Access Platforms have been around for 20 or 30 years in one form or another and have proven adaptable in different settings. This presentation is a brief overview of a tool developed to assist planning and budgeting, which you can download with the link below. So what is a Trusted Access Platform? As a platform, it is a foundation on which effective KP programs are built, on which a range of services can be provided. It is also a way of working with key population communities to establish trust and improve access to those services. Trusted Access Platforms may be implemented by CBOs or NGOs with support from government, but derive their effectiveness mainly from active KP engagement and participation. Trusted Access Platforms implemented well at local level are the building blocks for national programs at scale. As we go into more detail, I'd like you to think about your own KP communities and programs, what might be useful, and what technical support may be needed. We'd like to hear your thoughts on that in the discussion. Next slide. The what is needed for KP programs has already been defined. KP implementation tools describe this well in a phased approach from startup to strengthening in chapters and program management. More than 5 years later, however, implementation remains weak in many places and new proposals lack critical detail. This brings us back to a focus on implementation or the how-to, and of course to capacity building. SSLN recently reviewed TA priorities from high burden countries and found almost no requests for strengthening prevention with key population. This needs to change, and we're working on that. Next slide. Building a trusted access platform requires attention to intervention design and management. Intervention design comprises two main areas of focus: engaging communities with a continuous high-risk venue presence and providing clinical services promoted as regular medical checkups. As you'll see as we go along, uptake and retention of specific services for prevention, testing, treatment, etc., are boosted by this platform approach. Next slide. On the management side, scale and coverage are achieved by high-level gap analysis and planning to replicate platform building blocks at local level wherever needed. This in turn involves using local participatory mapping to saturate coverage and support implementation, monitoring key platform indicators of uptake and utilization against targets using routine program data, and building capacity and community ownership. Next slide. Outreach with continuous hotspot presence facilitates saturation uptake, frequent outreach contacts, and regular clinic attendance. How does this work? Planning begins with participatory mapping and population size estimates for each site. Peer educators are engaged where they live or work and enabled to conduct outreach based on their knowledge of their communities, venues where they meet, and rapport with peers. Supportive peer supervision takes place with weekly one-to-one meetings, reviewing the previous week's work, planning to reach targets, motivating, focusing outreach efforts, and ensuring timely monitoring. Investments in these areas build trust and engagement and lead to higher service uptake and retention. Next slide. This figure shows how planning follows from simple maps developed with peers, showing locations of high-risk venues and services with estimates of the number of key populations at each venue. From these mapping exercises, community is engaged, potential peer educators are identified, and outreach is organized around the venues with site estimates providing denominators for targets and monitoring. As part of this, the tool offers advice on planning safe spaces, structural interventions like violence prevention and response, and self-help groups, and strengthening outreach and prevention basics. Next slide. Regular medical checkups is a way to boost clinic attendance and reattendance, again by building trust. These translate into better uptake, adherence, and retention of specific services and optimal outcomes. Regular checkups are promoted by peers who don't need to know anyone's HIV status or confidential health details to encourage clinic visits. Promoting checkups rather than specific services safeguards medical confidentiality, builds trust, and simplifies peer educator training. Specific services are determined in confidentiality with a trained medical provider. Next slide. Trusted access platforms optimize coordination and communication between outreach and clinical services at a number of levels, as illustrated here. During outreach, peers promote services and encourage KP to visit the clinic for routine checkups. Quarterly checkups provide ample opportunity to screen, treat, and follow up common health conditions, as well as for monitoring PrEP and ART. When everyone in the community is encouraged to visit the clinic every 3 months to stay healthy, there's less stigma for those who need to attend for specific reasons. You can perhaps see how investing in this model of service provision and promotion can help with a number of common problems, including stigma, low service uptake, and loss to follow-up. This brings us to the question of how clinical services are provided, since all of this becomes more difficult when clinical services are outsourced and the program depends exclusively on outside referrals. Next slide. Clinical services can be organized and provided in a number of ways, all with cost implications. But keep in mind that savings in some areas may offset investments in program clinics. Here are several possibilities, from minimum to comprehensive services. Whatever is initially feasible, The tool recommends ratcheting up to provide services as close to communities as possible, from outreach only to adding safe spaces where government or other clinicians can be hosted, providing anything from basic services to full ART and related care. The more services can be ratcheted up near to and accessible to communities, the more they build trust and are likely to be used. Next slide. Moving on to management. The focus is on using program data to continuously strengthen implementation. Priority platform indicators based on clear targets for outreach and clinic attendance include first-time uptake and repeat contacts and clinic visits. Specific service indicators follow and make sense because they can be measured against population level targets. In all of this, ongoing monitoring by the community is critical to ensure quality and trust. Monitoring outcomes and impact can also be done, often without costly surveys. Next slide. Capacity building is essential and a priority for SSLN and the technical support mechanism moving forward. This figure shows how trusted access platform approach is being adapted in one country with national level direction and support for scale up, standards and policy, and implementation at district and local levels. A capacity building team or technical support unit, TSU in this slide, is essential to ensure national standards provide support and monitor progress. We will hear more about that, about how this works in Kenya in the next presentation. Next slide. So how do these various platform elements come together? You'll see how for Kenya in the next presentation, and Zimbabwe is another example. We're looking to tap into their experiences for south-to-south technical assistance to other countries. But here are some long-term outcomes. Starting with routine program monitoring and data from 2 districts in India, going back more than 15 years. Figures here show population estimates, the dotted lines, and performance, the solid lines. The platform was strengthened between 2009 and 2013, reaching targets for monthly outreach and quarterly checkups. The figures also show dips due to police harassment and funding interruptions, and then recovery when those problems were resolved. Community ownership solidified during this period, and important outcomes that were measured include large STI declines, new HIV infections decreasing from around 30 per year to less than 1 to 2 per year, despite a 10 times increase in testing. Also high ART and PrEP uptake and retention. These successes are attributed to building trust and community ownership, implementation with clear expectations and targets, and a continual feedback loop between community and program. Next slide. Before handing back to Parinita, I would like to take a moment to recognize the enormous contribution of Dr. Janna, who tragically passed away last month, and of DMSC. Their pioneering work in Sonagachi, West Bengal, and across India defined what community-led can mean and continues to guide work in this area. Thank you.
Thank you so much, Richard. That was a great presentation. Now we have around 7 to 8 minutes to open it up for discussions, questions, clarification. You can use the raise hand button near the chat box, and in case you want to ask any question, you can raise your hand and unmute yourself and ask the question. Otherwise, you can also write on the chat box. I see Dr. Margaret. Could you please unmute yourself and ask your question?
Thank you so much for the opportunity. This is Dr. Margaret Kagashe from Tanzania, leading prevention on HIV perspective of the National AIDS Control Program. I have just few issues. I just wanted a bit of the clarification. One is, the presenter said we had some specific interventions needs professional or trained people. I would just like to know which, when we say specific area, which area are we targeting, or which interventions are we targeting with these professionals? That is one. And a bit of learning part of it, I just want to know, how do you monitor in terms of feasibility, accessibility of the services in the community? Do you do a survey, or there's another modality which we can use just to monitor those the feasibility and accessibility of the services to the KB? Thank you.
Okay, thank you. Very excellent questions. The first one, in terms of specific services, I think I mentioned on the slide that in a few places that specific services are easier to provide when you have a strong platform. So the specific services, I mean, are everything that's on the list, which varies from country to country. WHO has guidelines about service packages. They often include STI screening, HIV testing, linkage to care, sexual reproductive health services, et cetera. The focus on the platform here is kind of to move back from that detail. It's to say, if you strengthen the platform, both at the community level to promote the services, and at the clinic level to provide good services, and particularly through this kind of idea of routine checkups, that you'll build trust and you'll get people using the services, and the uptake and utilization of all the specific services will be improved. We've seen this on the ground, that the better uptake and retention for any specific services. So we monitor first the platform and then the specific services. In terms of monitoring feasibility and accessibility, again, a critical issue, and I didn't go into much detail, but the monitoring slide is almost entirely programmatic data. So the accessibility and the feasibility is measured and reviewed on a monthly and quarterly basis by looking at the data from the outreach teams and the data from the clinics on attendance, both first time attendance and repeat attendance. And I showed some figures from the project in India on that. I hope that answers your questions.
Thanks, Richard. There is another question on the chat box and says, can you share some additional examples of a well-functioning trusted access platform project in Africa?
Okay, so we're going to hear very soon about Kenya, which has definitely meets those criteria. So I won't say anything about that. I work closely with Sisters with a Voice in Zimbabwe, and it's a program that has reached national scale with their program for sex workers, and has implemented most of these program elements for trusted access platform, including microplanning. And I won't go into detail there, but I think both of those countries have considerable experience in people who can actually provide technical assistance to others in neighboring countries. So that's in our work with SSLN, and also my work with coordinating technical assistance for the UN, for UNAIDS technical support mechanism. We want to see more of that kind of south to south assistance provided.
There is another hand. Tisha, you want to go ahead? Can't hear you, Tisha. Are you muted?
You can hear me now?
Yes, we can hear you. Go ahead.
Thanks. Yeah, I wanted to say, hello to many friends who I see here. And I think just to underscore, Richard, I think that, what you've done in articulating this trusted access platform is take a concept which we've been seeing since the days of DMSC and the work in Kenya that, is decades old. And it's kind of reframed, but it's really this evolution of, engaging the community and incorporating like a more integrated model, which is accessible to the key populations on the ground. And I think most of the people here who are real pioneers in key pop programming around countries have done something like this in a different way. And, it's really the goal, I think, of the USAID funded programs in PEPFAR. So, I appreciate the work. I appreciate the way you've articulated it. I think it's very clear and strategic, and I'll definitely be sharing this presentation widely. Thank you very much.
Thanks, Tisha.
Thank you. So Richard, we have two maybe questions before we move to the next presentation. One question that I see is, can you provide some perspective around relevance of capacity building for the KP community to overall success of the KP program? This comes from Chris. And there is another question from Joseph Kamanga, and he's talking about, can you share age profiles of populations, and if you have different strategies for older key populations, MSM, and transgender people?
Okay, thanks. The first question about capacity building for KP community, it is critical and should be a part of programming all the way. And I think Helgar will talk a little bit about this in Kenya, which does it well. It's very important. I mentioned at the early stage involving key population through identifying, through starting with participatory mapping, identifying key populations, getting them involved, involving them in outreach work. That's only the beginning. The strong programs have ways that KP can increase their capacity on the program side and move up in the program to become peer supervisors or coordinators or directors. So there's many ways, and it should be built in from the start. The other question about older KPs, I think, in terms of talking about this trusted access platform, I think it works across the board. I don't think that the platform would be done any differently for older KPs or different KP subgroups. Of course, the principles are general and can be adapted to programs anywhere.
Great, thank you so much, Richard. I'm sure some of the answers would be also provided when Helgar makes a presentation and Kholi makes a presentation from the community perspective. So we'll have to move to the next presentation at this point of time. Our next speaker is Helgar Musyoki, who heads the HIV Prevention Unit and the Key Populations Program at National AIDS and STI Control Program, NASCOP, under the Ministry of Health in Kenya. She is a public health specialist and has been involved in HIV programming for over 16 years now. She's been responsible for establishing, scaling up, steering, and managing the National Key Population Program in Kenya, which has also been identified as a global good practice today. Helgar is also the focal person for East African community HIV activities. I've worked with Helgar for several years in Kenya and have always admired her commitment, leadership, and ability to find solutions. Helgar will present now about the scale-up story of Kenya, especially using the building blocks for scale-up. Over to you, Helgar. Welcome. Go ahead, Helga, over to you. We can't hear you though. Can you hear us, Helga? We can see you. We see you are unmuted, but can't hear you.
Can you hear me now?
Yes, very clearly. Thank you.
Okay. At some point, I was muted centrally. Thank you so much, Pari, and thanks for this opportunity, SSLN. I think it's a great forum, and we are going now to look at the practical bit of what Richard Steen has really presented, and this is the real application of the building blocks. I'm hearing questions already, and now you can see the practical bit of what Richard Steen has presented. Thank you very much, and I appreciate this forum. Next slide. And just to introduce my presentation, Kenya is in the East African region with a population of about 48 million people, and the general prevalence of HIV is about 4.4%. And now to come to the KP program, I'll start with the contextual overview of the HIV program and the KP programming in Kenya. And what you can see there is a document that has talked about the historical perspective of a Kenyan program, giving the evolution of our program, the prevention program for key populations. So just as a reminder for those who know the Kenyan landscape is that HIV in Kenya is, we have a mixed epidemic, which is concentrated and also generalized, driven by the general population that account for about 44% of the new HIV infections, and a concentrated epidemic by the key populations that account for a third of all new HIV infections. The HIV prevention program in Kenya is critical for the Kenya's response and towards closing the gap. And key population program include, the key population in Kenya include female sex workers, the MSM, the transgender people, and the people who inject drugs. We have very high estimation of key populations, and we have about 197,000 female sex workers, about 61,000 MSM, 27,000 PWIDs, and 4,300 transgender based on the recent mapping that we have just disseminated. Key populations have a very high prevalence in Kenya. And just an example, 29% of our female sex workers have HIV, 18.2% MSM also have HIV, about 18.7% of the PWIDs have HIV. And this was according to an IBBS that was conducted some 10 years ago. And that time, the general population prevalence was about 6%. So you can see the HIV prevalence in Kenya is really key. Same-sex and drug use, same-sex relationships are criminalized in Kenya. And I know people have been asking, then how do you program in such a setting? And we're going to be showing you some of the examples of the success factors. Next slide. So in a snapshot for the Kenyan program, our program is spearheaded by the Ministry of Health, NASCOP and NAC at the national level and the county level, and of course working with the different stakeholders, but it is led by the government. We use a combination prevention approach that encompasses biomedical, behavioral and structural interventions. And in Kenya, the NASCOP provides strategic direction, set standards, and also technical support to the counties and also at national level, including some of our implementing partners. We generate evidence, we also mobilize resources, and we provide an enabling environment to ensure that we have service delivery taking place. County government ensures that there is efficient and effective implementation through the implementing partners and coordination at the county levels through the structures that I'm going to share. And currently the KP program is in 36 counties out of the 47 counties in Kenya, with funding support from mainstream government funds, PEFA, which accounts for about 68%, and Global Fund, which is about 20%, plus other donors. Our coverage as at 2020 December was 170,000, which forms about 87% of our female sex workers in the 36 counties. About 64,000, which forms about 105% MSM in the 34 counties where we have presence, and about 18,000 PWDs have also been reached in 11. We have about 4,000 MAT clients as at December 2020, and that is in 6 counties. Right now, the number is about 8,000 and our retention is about 83%. Next.
Helgar, there is
Yes.
a request by the interpreters to go a little slow as they are translating. Thank you so much.
My weakness, I'm sorry. So just to touch on the building blocks, we have several building blocks, and just to put the practical perspective from what Richard Steen has shared, one of the building blocks is setting up a coordination structure for startup. So for any program that is starting, you have to have a coordination structure. And for Kenya, we established the National Key Population Program within the National AIDS and STI Control Program, and that was in 2009. Then we had a TSU that was established in 2012 to support the national program, and this is because we thought as a country we did not have the capacity to have a program that is scaled up. So we asked for support, and that's why Paris is here, and it has been an incredible journey. We formed multi-sectoral technical working groups at the national level with membership from the key populations, implementing partners, donors, development partners, and the technical working groups have been meeting quarterly for the last 11 years without missing. In 2015, we had a discussion as a country after devolution, and this is when we decentralized government, and the health services were also decentralized, and therefore the county level KP technical working group started forming. Currently, we have about 32 out of the 36 counties where we have KP presence. All the technical working groups have subcommittees that discuss specific matters that are technical in nature, and they have involvement of the key populations themselves as the community beneficiaries. We have the technical working group at the high level, just to the illustration. And then we have the subcommittees, and some of the subcommittees are advocacy subcommittee, we have the capacity building subcommittee, and we have the monitoring and evaluation subcommittee. At the county level, it is replicated, and we have the same subcommittees at the county level. At national level, we also have the harm reduction technical working group, which is a subcommittee. And we also have other forums like the MAT linkage forums. And this is for implementers who are doing the medically assisted therapy programs, because we realized that their space was always very small when it came to dealing with other KP matters. Next. The next building block is basically ensuring that you have a policy environment for the program that ensures that you can actually do the programming. And because, you know, in our setting, sex work, same-sex relationships, drug possession, and use is criminalized. However, the KPs, that is the female sex workers, the MSM, the people who inject drugs, the transgender people are prioritized in the National Strategic Plan. And we found this as the country to be a game changer. The moment you embed some of these very, and I would not say controversial, but in some countries they will say they are controversial programs, you will find that if you embed them in a government policy document, then it is easy to convince other relevant departments in the government to program with you from a public health perspective. We have the national guidelines for key populations that has all the populations mentioned, and this was guided by the suite that Richard Steen presented. We have the national policy for key populations for the prevention of HIV among key populations developed in 2016. We then have the guidelines for the young key populations, and we are hearing questions about how do you program for the different age sets. And we developed these out of need, and when we realized that we were leaving out the underage in programs. And then we have the national guidelines that is brand new for Kenya for the transgender people, because again, it is a subgroup among the key populations that has to be targeted if we have to get to zero among the key populations. That is an example of one of our national guidelines. and we have all the others. Thank you. Next. The other building block is basically planning for scale. And what does it mean when you say you want to plan for scale? You need to map, you need to have your population size estimation as a first key step. So we did the geographical mapping in priority towns. That time we still were not devolved, and we had provinces. We had about 10 provinces in the country. So we sampled a few towns. Of course, we characterized the towns that would have some of the key populations, and that was in 2012. And then we did a participatory programmatic mapping approach in 34 counties, and that is where we had programs already in 2018. And then we recently did the mapping and estimation virtually, just out of need. And you'll realize that when you're planning for scale, you will have to listen to the programs and really align to the needs of the program. So this was a need that was highlighted by the MSMs, that most of them were actually now going to the virtual spaces. And no wonder we have about 25% of the MSM who are seeking services in the virtual spaces. And we also realized that those 25% were actually not going to the hotspots. So even if you did a thorough hotspot mapping, you still would not get this virtual MSM. So size estimates are derived in counties without programs using mathematical modeling. And we had counties that we did not have this geographical mapping, so we just did a modeling. And right now as a country, we are saying that we have size estimates for the whole country in all the 47 counties. And again, this is again planning for scale because we want to scale up to the 47 counties. Mapping and estimation exercise helped in identifying where, because when you map in the hotspots and how many, then you're able to know as one of the building blocks, how many key populations are in that hotspot. And you can actually say that the commodities will be XYZ. Then they helped in setting targets and guiding the scale-up program. Of course, we are aligning to the 90-90-90, now 95-95-95. And without the targets, it's impossible to do that. So again, when you're managing scale, this is something that you need to consider. Then at implementation level, there is usually participatory mapping, which identifies intervention locations, venues, and this is where the key populations would operate in those hotspots. And that is just a map of how we visualized our country in terms of the interventions that we have put in place. Next. Strengthening outreach is again another building block. Community outreach is prioritized with peer educators and the outreach workers as a backbone. You know, peer education is a backbone for programs that are targeting the very hidden populations. Peer educators who are KPs are selected from the mapped venues and in many cases by the KP community in the venue or location. In Kenya, we have the peer ratios as per the national guidelines. And for the female sex workers, we have one peer who is supposed to take care of about 60 to 80 female sex workers. For the MSM is one peer for 30 to 40 MSM. For the PWID is one peer for 30 to 40 PWIDs. And for the trans people is one peer taking care of 30, because this is a very new program which is very intensive. At another level, there is a supervisory cadre of the outreach workers, which is very critical. And again, this is again stipulated in the guidelines just to ensure that there is standardization. And because we have also matched the peer ratios with the access to services, and you find that one outreach worker is able to take care of about five peer educators as a supervisor. Outreach workers who are also KP interact with their peer educators on a regular basis to review their performance and support planning and monitoring. Peer educators are encouraged to perform well and progress to become outreach workers and later to become program officers. And we have seen this motivating peer educators to really work hard and make sure that they maintain their cohorts and be able to engage with the communities in the right manner. Next. The other building block is about engaging communities with continuous high-risk venue presence. For a program that is working, there has to be continuous, presence in those hotspots, in the dens, and the outreach team is trained on peer education skills, planning at the venue level using the relevant tools for each key population member in their cohort, using very simple participatory tools. Now, as peer educators work in the venue, they are expected to be present in the venue for most of the days. And this is one of the evaluation mechanism that we use. Virtual sites are emerging as venues, especially for the MSM, and hence virtual outreach is also needed to make sure that there is contact and that we provide services. For the outreach services, they include provision of information, condom and lubes, needle and syringes, referrals to clinics, and many other services. The outreach team plays a very critical role in mobilizing key populations to access clinical services and follow-up, and it is a way of demand creation for all the services. The outreach team also provides support to the key populations when they experience violence, and there's a violence response team all the way from the grassroots to the national level. Next. There are safe spaces, and again, safe spaces provide a very good avenue for the key populations to engage and share their experiences, have education taking place, but also to make sure that they're able to engage. I'll give an example of the drug users. The moment you disconnect the drug users from the dens, then you need to create a safe space where they can socialize. Now that they are not taking drugs and you want them to start taking methadone, they need to socialize because human beings are social animals. Safe spaces in the dropping centers are part of the guidelines in Kenya, and we've also developed the standard operating procedures on how to establish a dropping center or a safe space. Difference between the clinics and the dropping center, and we have the same SOPs that will be able to give you the difference between the two. And then dropping centers are meant for relaxing, socializing, and normally designed for by the KPs themselves. They'll tell you we want yellow pillows, orange pillows, so we listen to them, and that is what we follow. And then the KP-led organizations have a better understanding of the dropping centers. So their dropping centers, even in Kenya, you'll find that they are more exciting to be there. Next. We have a pillar and a building block that talks about structural interventions, and these are interventions that will create that enabling environment for service delivery. They are guided by an advocacy strategy that guides the development of the environment, the enabling environment for implementation of the KP response. They focus, the focus for these structural interventions has been violence prevention and response, among others. And there is awareness of rights among KPs that is usually advocated for. The crisis response system at all levels. There is sensitization, engagement, and training of the law enforcement. And then there is usually a dialogue and advocacy with the court users committees. And especially in programs where we are talking of the non-custodial sentencing as an alternative to incarceration. Effort has been made in reducing stigma and discrimination in the health sector. The KP-led organizations have initiated economic empowerment activities as one of the structural interventions. And there is the collectivization and strengthening capacities of the KP-led organizations. And I'll show you some of the examples of the success stories of some of these interventions. Those are some of the IEC materials that we have been able to develop in collaboration with the communities. And these are used by the programs to just ensure that we have standardization in the way we implement some of the structural interventions. Next. You have to continuously optimize the clinical services. There is an SOP for Kenya that really tells you how to run the dropping centers, how to conduct clinical outreaches, and how to provide basically all the clinical services. We have different models of clinics. When we started as Kenya, we had we started with the static sites, which are standalone sites also, and they could be government-led or they could also be led by the communities or the other implementing partners. We have outreach clinics that complement the standalone clinics because you cannot wait for people who are not coming to the clinic. If you find that during your site load assessment, that 50% of your members are not coming to the clinic, then you go out to look for them, and that's why we have the outreach clinics. And then we have integrated models of clinics that are in the government setting, but they are run together by the CSOs and government. In these clinical services, we offer comprehensive services like we have HIV testing, STI, PrEP, SRH, condoms and lube, ART services and other special services. There is emphasis on the quarterly checkup just to ensure that you don't have missed opportunities. And then there's a focus on improving healthcare seeking behavior, and then a strong linkage between the community and the facility teams. The two teams have to work together because one is creating the demand and the other one is providing services for that demand that has been created. Next. The other pillar is basically having a meaningful engagement with the key populations, the community, ensuring that you give them confidence, that they can trust you. In Kenya, we have KP-led organizations and networks that are part of the TWGs and subcommittees. In the TWG, everybody is equal and your contribution is equal, but there is a leader, of course. And then 25% of the key population implementers in Kenya are KP-led. And this was more from an affirmative action by the Global Fund, which really has assisted us to really move and to have KP-led organizations really moving the implementation. The KP-led organizations and the representatives are involved actively in developing guidelines and manuals and SOPs. All these manuals that we develop from the day one, we develop with the key populations themselves. Then they've been involved in the mapping and estimation exercises. They've been involved in research and monitoring as research assistants. Some of them are co-investigators and PIs in different studies. And then they've also been involved in writing the country proposals, like the Global Fund proposals, and right now very actively engaged in the COP21 discussions for Kenya. And then they are the stakeholders, they are stakeholder peers. We have special spaces that have been created, like the peer convention, and you can see an example of one of the peer convention. And this is usually a safe space that government provides to all the peers in the country, and they come together and they are able to tell us the challenges that they're getting. These days, no implementers are there. So we allow the peer educators to say anything, and it's usually almost like a closed door meeting where the peers can actually be able to talk freely. They can even tell us we've not been paid for the last 1 month, and they'll get a solution because the implementer will be called and we know what the problem is. And we've been able to solve many challenges, and some of the solutions have been found through those mechanisms. Next. Somebody asked about the monitoring performance, and in Kenya, we have monitoring at all levels. Again, this is a very critical, a very good and a very critical pillar for the Key Populations Program and one of the building blocks. Standard national tools have been developed for Kenya, irrespective of the donor, and all of them, all the donors, all the implementing partners use these tools. And what we have done as a country, and every time we are revising these tools, we engage all the partners. Maybe PEFA has a new indicator that they want included. Instead of PEFA struggling to go to the partners and tell them that you need to report to this tool, we support PEFA to see the meaning of that indicator, and then we nationalize it and make sure that all partners are able to report using that tool. That way, then we are able to really have the government system being superior than all the others, and all the others can follow using the government reporting tools. And then simple data tools for the peer educators. We have the peer calendars that are used by the peers, very simple. Even for the ones that have not gone to school can use those tools, because if it's like a condom, we also provide a picture of a condom, so you don't need to have gone to school to use that. But basically, the uptake of these tools has been really amazing for the populations that we are serving. We have about 400 plus units that are reporting monthly through the Kenyan Health Information System. And then the quarterly reporting that started way before we were able to move to the national platform. You realize that in countries that you'll have to advocate for your space to even be included in the monitoring system. And for Kenya, we found it very difficult in the initial years to really have this reporting system integrated with the others. And what everybody was telling us is that we cannot integrate what you don't have. So we had to make a very good reporting system that then later can be integrated. And now we are very proud that for the last 3 years, we've been able to implement a national reporting mechanism. There's analysis that is done for data, and the presentations are done during the quarterly donor meetings so that you don't shock the donors during the TWG, and that they can also provide answers. I know some of the donors are here, and they're usually, initially we used to have donors complaining, why do you always shock us with data that we have not seen? So to avoid this, we now have closed door meetings with our donors. They see these presentations beforehand, and then now we have the TWG presentations. And then at the county level, they will have done their TWGs, and now they can report to the national TWG. And then at the implementer level, and that's why the technical support unit is very critical. We have officers that are able to engage with the partners on a monthly basis at the implementation level. And then we have the annual behavioral surveys, like the polling booth survey, which is rapid, scalable, feasible, and is cost effective, and is able to give us very quick behavioral data. And of course, every 5 years, every 4 years, but for Kenya, I think it has been 10 years because of some challenges. We have the integrated behavioral survey that is supposed to measure the impact of your programs. Then there is development of the cascades. This is a new thing that we have implemented, and this shows you every gap at every stage of every prevention intervention that you have, and therefore you can know where to intervene most. Next.
Okay, I'll just remind you a little bit about the time. I know you have the last 2 slides. Thank you.
Thank you. Then I think I'm almost doing my last slide. Capacity building is another building block that is very critical, and somebody has asked about that. It's a critical aspect of the KP program. There is specific cadre-wise training. Somebody has asked that. The outreach team is trained differently, clinical team, and the program management. And then there is the joint training with different stakeholders. Some sensitization manuals have been developed for the healthcare workers and also the police. And then TOTs, either trainers of trainers, are conducted at national level, and they are used now to cascade down the trainings. Capacity building plans are done every quarter, and we certify centrally for all the trainings from the peer education level. There is we use a platform called TrainSmart that we are able to centralize all the trainings that are certifiable, and we are able to certify every quarter. Thank you. Next. Sustaining the KP program coordination. You saw this pillar when you are starting up, but this has to continue. You have to continuously engage, have the TWGs on a quarterly basis for us, and then meet quarterly at the county level and national level, allocation of resources, quarterly donor meetings, the annual peer conventions, annual stakeholders, and then the technical support unit, which is embedded within the national program, is able to also continue engaging the service providers at the county levels and also at the national level. Next. So we have lessons learned from our program and from implementing those pillars. So in an environment where behaviors and practices are criminalized, the government needs to take leadership, and this gives confidence to all the implementing partners that what they are doing is right. Meaningful engagement with the KP communities, implementing partners, funders is also very essential, so that all of you are on the same table and you can resolve issues immediately. Development and implementation of the national guidelines as a standard, and I know Global Fund has been doing this to just look at whether you're implementing as per your national guidelines as a benchmark. And then continuous and sustained advocacy in a devolved system for Kenya is very critical. Continuous monitoring is one of the pillars to measure impact and also the progress using the tools that we have also provided. And then acknowledging and addressing emerging gaps like mental health, young key populations, virtual interventions, the transgender programming. All those are areas that have emerged for the Kenyan program, and we've learned that you need to intervene. I think that's next, Barry. Thank you so much.
Thank you so much, Helgar. That was a wonderful presentation and kind of flowed very beautifully from the presentation that Richard made. You kind of made the Richard's presentation actually come to life. I know we have a very short time for question and answers. I have already noted some of the questions from the chat, so I'm going to read out those questions so you can respond to it. So there was a question about stigma experienced by key populations by health worker in the healthcare services. So the question was, do you have any experience or success story about how you have been able to reduce stigma in healthcare settings. That was one. The second question was, are the monitoring tools that you are mentioning about, are they national tools, and can you share it with us? The third question was, I can read it again in case you want to respond, but the third question was annual BBS, I think it's biobehavioral survey. Would you suggest annual IBBS or biobehavioral surveys, or should it be, should the frequency be a little bit more or less? And if you have any recommendations for it. And the last question that I could see on the chat was that, do you have any programs for partners of key populations, especially clients of sex workers, because they seem to be having also high incidence rates of HIV? Yeah, over to you, Helgar.
Thanks, Pari. I'll start with the question on the annual surveys. Usually the integrated biobehavioral surveys are very expensive, and countries have come up, and we are learning from other countries that have gone before us, like the Asian countries and some of the other countries. Polling booth surveys have become very scalable and can be used by programs on annual basis. They're cheap, they're easy to execute. You can use local capacities once the protocol is done, and they give you very quick information. For example, you're able to know at the program level how many people have STIs even before you leave that the venue for the study. So they are very quick, and they can give you very quick answers on the way you're implementing. However, the polling booth surveys can only be done where you're implementing. Where you do not have presence or where you do not have programs, then you cannot do a polling booth survey. So it is good only when you have a program that is running already, and you can now measure the progress of that program. The integrated behavioral surveys, again, are very expensive, but the sure way to have the impact of your programs. And I think the only way we can do is advocate for more resources to be able to do the integrated behavioral surveys, but they are really critical when it comes to measuring the impact of a program, because they touch on where you have presence in the program, but also capture the other people who are not in the program. So I think for me, I would recommend both. And where you do not have resources, I think you can always do sampling, and we can talk about that in another maybe forum where you can now do proper sampling for the IBBS. Programs for the clients, essentially programs, when we say sex workers and their clients, we normally, and because they're in the hotspots, it's usually implied that the clients will be reached out. But we have seen very few programs really reaching out to all the clients of the sex workers. But we have strategies that have come in, for example, the index testing, the social network, that have proven that you can actually reach out to clients in a very easy manner without having to shout that you're actually reaching out to the clients of the sex workers. But yes, you can reach to the clients of the sex workers, and our programs have been able to reach. What I cannot really defend is the reporting, because a client of a sex worker is a member of the general population, and many times the sex workers programs, for example, will not report the GP members. They'll only report the sex workers. So usually they're missed out in our data. And when you're not captured in data, then programming for you is very shaky. But I know programs are doing, and they are reaching out to the clients of the sex workers, only that we do not have national data for the clients of the sex workers, because our data is also not disaggregated by clients of the sex workers. Pari, if there is no time, I can do the responses on the chats for the other questions.
I think there's one very key question, Helgar, and that was about sustainability of the program. I think there were 2 or 3 questions around it. Domestic funding for key population programming. Maybe you could take that as a last question and then respond to that.
Okay. From the practical bit of it, many governments will take domestic financing for commodities. So if you really want to be smart, then let government take over the commodities first, and then slowly move to having some of the interventions being taken up by the programs. where you can defend. But from our key populations program and from our history, I think right now what has been taken by government, almost 100%, is the commodities. Apart from the needle and syringe program, I think most of the other commodities it's government that is procuring. And then we have support so from Global Fund for some of the MAT commodities. But from a practical perspective, for the KP program specifically, what governments will take up is the commodities. The other area governments can really take up for the domestic financing is issues of human resources. It is very possible for dropping centers to have human resources from government, and that is one way of financing the dropping centers. In terms of the real interventions, like outreaches, paying peer educators, what Kenya is right now doing is that we are trying to see whether our peer educators can actually be enrolled in the community strategy at the county level, so that when you pick a peer educator who is a sex worker or an MSM or a PWD or transgender, then the same peer can actually be used even for polio campaigns, immunization, and all that, so that then they become government officers at the community level. So that's another way of making sure that you have some resources for the programs. But in terms of allocation of resources like cash money from government for KP program, I think we are still very far from that, and it's an area that we continuously need to advocate for.
Thank you so much, Helgar. There are many more questions on the chat box, so I think you will have to be active and responding. I also saw there was one question from Annette in the beginning about the number of MAT clients that are registered, and so maybe that could be also responded. So, but we'll move ahead and to the next speaker. Our next speaker is Kholi Buthelezi, who is a feminist activist from South Africa. She is the founding member and national coordinator of Sisonke National Movement, which is currently based and hosted within SWET. Kholi has experience in many spheres of work. She has progressed from being a peer educator to outreach and development worker, progressing to African Sex Workers Alliance, ASWA's country coordinator, then a member of the SWET management team to the current position in Sisonke today. She is an active global advocate of sex workers' rights. I have not personally worked with Kholi, but do know her as an amazing key population leader and a very committed advocate. Kholi, over to you, please. Welcome.
Thank you so much, Parinita. Good afternoon, South African time. So my presentation, I'm gonna be talking on key population leadership and ownership in scaling up the key population program. We are the movement in South Africa, so the background is already been shared. So the purpose of us building the movement, it does speaks to leadership and ownership in scaling up whether it's healthy or human rights program. So the background in South Africa, the movement was formed and launched in the Cape Town at the meeting that took place in the Western Cape as the leading human rights organization in South Africa, led by for sex workers. The movement was founded in the premise to promote and protect the health and the legal human rights of our fellow sisters and brothers. The purpose of the movement at that time was to develop the national solidarity to date amongst the sex workers and become more organized in response to the issues that we faced in the working environment. So the movement's vision is to see South Africa where sex work is recognized as work and where sex workers' health and human rights are ensured. Our mission is to make sure that our aim is to unite sex workers, improve living conditions and working conditions, and fight for equal access to rights. And we believe that united we have a voice, divided we fall. Next slide, please. Sisonke's best practice to achieve the aims are through the following implementation programs: leadership and capacity building. Secondly, it's human rights defense, advocacy for the decriminalization, institution building through the development and strengthening of the provincial offices and national offices. You see, the picture is us with the sex workers and Sisonke members on the street advocating for issues that sex workers are facing in South Africa. Next slide. Under leadership and capacity building, as you see the pic my colleague is facilitating there, we hold the creative space workshop to develop safer space for sex workers to focus on issues that concerns them. And together with sex workers, we have discussions also on how to overcome those challenges. We also conduct a regular outreach to recruit members and also to reconnect with existing members and explore new ways of organizing. Our outreach also is more focusing on the human rights aspect. We do carry the safer sex material because sometimes it's not easy to engage with sex workers, when they're in business, but then we make use of the safer sex material as an entry point. We sometimes work with Sweat, whom they do healthy, most related services. So we then also refer to them around healthy needs. We undertake condom and lubricant and IEC material distribution with the aim to cascade the information sharing through indoor and outdoor outreach, as well as to educate sex workers, because the IEC material also is more in education. Sometimes people don't have time to read, but we do ask them and please them to say, can you read when you have a spare time? Then we make it the contact and also building partnership with them for any questions that they might have around the IEC material that we have distributed to them. We also train sex workers with Sisonke owned developer trained manual. It's called rights-based self-development. Sex workers are trained on a variety issues pertaining to the issues that they face. The training, the rights-based development training, it has actually capacitated the sex workers to become active leaders on their own, because it gives them ideas of how to approach, or also to think whom are the target audience and how are they going to approach the target audience. Our role in technical assistance that we provide to them after we have capacitated the sex workers, it is to maybe write the invitation to the specific government relevant person, whether it's Department of Health, if it's an issue about condom, or if it's an issue about the treatment towards the clinic. We facilitate, we facilitate and coordinate that kind of processes, but the sex workers themselves are the one leading after we have trained them using the rights-based self-development. So it is more on giving sex workers and boosting the self-esteem on how to actually take a lead on the issues that they face by themselves. Next slide. So under the human rights, this is what we do. We mobilize sex workers to speak out about the human rights abuses that they experience. And also we offer emotional support and express solidarity with sex workers who speaks out through a court support program. We encourage the use of the national helpline by promoting the toll-free number. You'll see it my last slide, these contacts are there. We also conduct the human rights workshops amongst the sex workers, and also we capacitate the sex workers in the peer education and the paralegal support. In the peer education and the paralegal support, both the sex workers in the peer education and also in the paralegal support, because we believe that as a form of best practice, peer-to-peer, it's always the best practice. Next slide. Under the advocacy for decriminalization, we support the local efforts to meet with the provincial and local leadership, speaking confidently about the decriminalization. We also participate in media liaison and highlighted the local concerns of sex workers, because we believe that the media platform also is the best mechanism that we can use to do advocacy, whether it's around health or it's around legal concerns. We also participate in local organizations, service provider, or provincial structures representing sex workers and promoting the health and the human rights of sex workers. For an example, let the Provincial AIDS Council Service. You see a picture, it's me and my colleague. We are at a dialogue with the DA, Deputy Minister of Social, the Deputy Minister of Social Development, with the support of SANAC, UNFPA, and Beyond Zero. That was in a great, a successful dialogue that we've conducted on that day. So that also shows that sex workers are leading. Both me and my colleague in that picture, we are sex workers. Next slide. The fourth one, institution building through the development and strengthening of the provincial and national our responsibility to make sure that we capacitate the provincial office bears to oversee the smooth running of the organization. And most of our offices are run and led by sex workers. We ensure the infrastructure capacity of Sisonke in all provinces. We also ensure capacity within Sisonke is built at all levels. And which that also include the meaningful participation, the creation of meaningful participation of sex workers. It is essential to build trust and establish the relationship. Sex workers organizations become more empowered. Partners should provide technical assistance and support. And allies also are playing an important role in facilitating the meaningful participation of sex workers with the community self-management. And the shared goal is the best practice of a greater results. Key population also are intersectional in nature finding of sex workers who are trans women and injection drugs users is a common cross sections. So therefore, having Sisonke partner and work with other stakeholders, government, NPOs, and service providers, it's a paramount to ensuring that the collaborative best practice model are utilized to their full potential. Next slide. On key population community leadership around health, aligning Sisonke sex workers movement with organizations that offer stigma and judgment-free services such as HIV prevention, family planning, say, STI screening and treatment, PrEP and HTS, by ensuring the above services are being offered at either fixed on a site or via mobile clinic. Organizations are better positions to provide sex workers with services in the communities. So then in this instance, we as Sisonke, we then become the middle person. We work hand in hand with the organizations that are providing the healthy services. If then we come across a sex worker that might in need of healthy services, then we do the referral or we accompany them straight and refer them in person. And Sisonke has a long history of working with Department of Health Hanover, Healthy Foment, the Global Fund, and partners all over South Africa to ensure that the sex workers are informed of their healthy care rights, because it is our responsibility, which is why the movement was built, is to make sure that the sex workers services that I need are being actually catered to. And addressing the 95, 95, 95 targets with the sex work keep up would not be possible without a buy-in from the movement like Sisonke. As I said earlier on, that the movement then becomes a middle person between the sex workers on the ground and the service provider. 95% of sex workers who know their status, we are on treatment and also viral suppress targets Sisonke is invested in. Next slide. Sort of got flu. So the key population community leadership continues. This is more on social services. The training of sex worker peer educators all over the country ensure that sex workers are able to receive counseling services from their own peers, which this also is part of best practice, and it has been working very well. Having counselors, social workers, and partnering with institutions like UCT, UWC, SACAP, UNISA, better positions Sisonke in spaces where psychosocial health services are paramount to addressing sex workers' need as a key, as key pop. Further to this, our sensitization training office social workers nationwide assisted us in breaking down many of the social nuisances and barriers that decrim causes when it comes to accessing to social services. The sensitization training also, it has been done with police officers. Recently, we've been receiving phone calls in the provinces whereby the police officers are the ones that are requesting the sensitization training to be done. Last week, my colleagues were trained on the dignity diversity training. They will be the one also leading those training in provinces. Social media outlets like Facebook, Instagram, Twitter enable Sisonke and other sex workers to voice their lived experience, and further giving those in the non-key population community an insight into the lives of sex workers. As I said earlier on, that the mechanism of social media as the best mechanism that we also use in making sure that the voice and the lived experience of sex workers, it's known, and in that way, we're also trying to get a buy-in and also to educate people to understand what are the issues that sex workers are facing and also to seek support. The views is often quite different. And we also make sure that what the general population assume sex workers to be, or they should behave, or how they should behave. So mostly the views are around that. But I think if it's sometimes in some platforms, you find out that meeting interviews, they will give opportunity to callers and people are calling in, and then we're able to respond than if it's an article that has been published. And most of the support has been actually positive in most of the media interviews that we have done. The challenge is just when the articles are being published are too like I was reading an article now, they showed a lady with a mini skirt and a person that would look so untidy. But we have done in South Africa, we have also developed a journalistic guide with the support of Sisonke Gender Justice Sisweti, and Sisonke that actually teaches media on how to represent or write an article around the sex workers. Next slide. The social footprint, other formats where Sisonke ensures that its footprint is relevant, and it is by taking part in the research studies. We have had Sisonke members and sex workers that have been trained to do the research on the ground, and that makes the research to be more effective because it's done by peer to peer. Believe me, it is best practice, because if it's my fellow colleagues, she doesn't hide anything from me. But if it's somebody else, I won't be able to tell everything because I'm just so worried about the stranger person that I'm talking to, on how my information that is going to get where and how is it going to be published. But we have been involved in many research in South Africa. They are often funded by donor organizations who need to understand how sex workers' lives are impacted by the laws, by stigma, by healthcare and policies that are often put women and the LGBTI sex sector at risk. And those research you make use of in terms of doing advocacy to change the lives of sex workers in terms of accessing healthy and legal services. As you know, sex work in South Africa is criminalized, so therefore it is challenging to access the healthy facilities. We depend on organizations. Other endeavors undertaken by Sisonke includes the human rights defense training, the sensitization training of the police, and also empowering sex workers with the movement building activities, which this is very important because if we then empower sex workers with movement building activities, they then begin to understand the importance of being part of the movement, because more voice will be more listened to the people that we actually handing over our challenges that we face. Lastly, having matches and community advisories meetings also enables the movement and get the message across non-key members of the sufficient. This recently, on the 27th of May, we're participating in a match that was actually called by the celebrities, which to us, it was a success because that shows that the movement is now well known. The theme of the match was "Funk It, I'm Walking It." So it was it turned out as a massive match, and I think it's quite a great achievement to have people that are well known and the high level people that are supporting the match. It shows that they are see the need of sex workers issues being actually highlighted than just to be us as a movement calling for the decriminalization of sex work or advocating for healthy access or handing over a memorandum about whatever that we're handing over or any concerns that we face. So it was actually a great a outcome of the match that we've actually conducted recently. Next slide. When we talk about community empowerment, as you see, we have actually created a booth, as a sex worker booth, so we target public areas where we know that places like subway, places like railway stations, places like taxi rank, places like park, to make sure that we display, as you see on the table, it's the safer sex material. Then people will come and ask questions, because as you see, the booth it's written "Ask a Sex Worker." Then that's when we get to make sure that we educate people and also sensitize them. Some they come with negative attitude, but when they leave, they now do understand the importance of sex workers also needed to access the safer sex material and healthy care facilities. And under community empowerment, it is a process that takes significant time and effort, especially since in many contexts, sex work is stigmatized and criminalized, as I said earlier on. Trust, empathy, and respect is important for all partners, and building trust involves treating sex workers with dignity and respect, listening to and addressing their concerns. The goal is to cultivate a program that eventually run entirely by sex workers, where sex worker-led organizations are respected as partners and by officials and service providers in the health, law enforcement, and social services. I'll make an example. Recently, we have trained the sex workers through the support of South African AIDS National Councils, the UN, and the AFSA to train sex workers to do the survey around COVID. It was a successful survey that the team conducted. They're now trained to do the reactive program. So they're documenting the human rights violations, which then the results is more effective because it's done by the sex workers themselves to other sex workers themselves. But I tell you, we've created a WhatsApp group, communication is flowing. And some of the things that they've said is that they will really need a debriefing after this because the issues that they come across that they're discussing, and some of the issues are not only from the sexual community, are from people that are non-community. So they did ask that, can you make sure that we do get a debriefing because this is so touching. And I'm sure some of the stories are related to experiences that sex workers have experienced under the criminal law system in South Africa. Next slide.
Kholi, I would have to request you to wrap up. I know you're coming to an end. Thank you.
Okay. So on the COVID impact of sex workers, depending on the existing inequality experienced, marginalized communities such as sex workers, following the pandemic, we included the lockdown in South Africa. Sex workers faced this listed: severe loss of income, inability to access any form of social support, inability to access basic necessities such as food, increase of stigma, discrimination, lack of access basic healthy. We have been we have to adapt in the face of a crisis. We developed new ways of working, such as through WhatsApp group and digital. As you see, these are some of the posters that we have actually created during COVID. Next slide. These are some of the Sisonke achieved. We've achieved too many things, but I just listed a few. Sisonke developed this Relate, which is a newsletter that we partner in partnership with the African Center for Migration. It's now proudly owned by Sisonke and led by sex workers because the transformation has been done to hand over the Relate to be run by Sisonke, and the stories that are shared on it are sex workers. Then I've spoken already about this rights-based self-development training, and Sisonke members are on part of the opportunity to conduct a survey. I've already talked about this, and the sensitization training led by sex workers. I've spoken about this, and the registration is an achievement that granted Sisonke a voice. This is a certificate of showing the greater partnership with the LGBTI community because there is intersectionality and also there is cross-cutting issues within the sex workers. There is the LGBTI community, so we felt and realized that the importance of working hand in hand with the LGBTI plus a QA plus QA a community, it is important. Next slide. I think I'm almost done. So Sisonke now, as you see, this is the Sisonke members. We actually sponsored and supported by South African AIDS National Council with bags and also the goodie bag of the COVID stuff such as sanitizers, etc. And we are now registered and recognized as an NPO. We have presence of membership in 9 provinces. Sisonke is having 60 offices in provinces, and we officially sit within the National Sex Work Sector of South Africa, recognized as of 2011. Sisonke as a human rights defenders in 3 provinces where we don't have offices, so meaning that we've covered the whole South Africa because it has 9 provinces, and we are based at Soweto where it is administrated and supported to achieve our goal. And we are in the process to actually transit. We've already found the office. By next year, we'll be fully independent. Sisonke does not work in isolation. We develop a partnership across the country to support the sex workers. I'm sure this is my last slide. The next, if you need help, this is our contact. As you see the picture, this is one of the outcome of a sex worker-led organization in South Africa being part of the National AIDS Councils and sit within the AIDS National Council as a sector. On this day, this is the President Cyril Ramaphosa at that time when we launched the sex worker HIV National HIV Plan. He was the deputy chair. He was the deputy chair of the SANAC sector. SANAC Civil Society, sorry. So we launched the first ever South African National HIV Plan. It was an achievement. Those are some of the success. Recently, we have actually participated in the co-chair of the South African National Human Rights Plan, which it has 7 programs: legal support services, reduce of stigma, reduce of gender inequality, sensitize lawmakers, legal literacy campaign, sensitize healthy workers, and monitor review and laws. I would end here, but I'll be able to answer any questions that you brought to my attention. Thank you so much. This is my last slide. I was participating in the multi-stakeholder hearing. Thank you.
Thank you so much, Kholi. Thank you. Such an inspiring presentation, and also showing us how KP-led organizations and networks can actually lead and support the scale-up process. That was a great presentation. Thank you.
Thank you.
I know that there will be many questions that you have for Kholi, but at the same time, I would ask for your indulgence to stay in this meeting for another 5 to 10 minutes. I know there are several key populations activists in this meeting too, and I would like to give opportunity to 1 or 2 of them at least to share some of their experiences. I see Akram, I see your hand is up. Can you just unmute yourself? Akram, please बोलिए.
नमस्ते सभी को नमस्ते। मेरा नाम अकरम पाशानोर है। मैं एक मेरे सेक्स वर्कर समुदाय से हूँ। मैं कुछ 2-3 मिनट बात करना चाहता हूँ। क्या रिक्वेस्ट है कि मैं आप बात कर सकता हूँ। और दूसरी चीज है कि मेरा ट्रांसलेटर डॉक्टर सुशेना के साथ ट्रांसलेट हो तो मेरे लिए आसानी होगी मेरी भाषा में बात करने के लिए।
Sure. Akram, please go ahead and speak, and Dr. Sushena will translate what Akram wants to share. Thank you.
थैंक यू वेरी मच। ऑल ये सभी प्रेजेंटेशन रिचर्ड सर, हलगा और खोली का जो प्रेजेंटेशन था मेरे लिए बहुत ही यूजफुल था और बहुत अच्छा था।
Hi, this is Sushena. So what Akram is saying is that, thank you very much for this opportunity. And he introduced himself that he is Akram Pasha. He is a male sex worker and he is from Ashuda Samiti. He also said all the presentations that he has been hearing today, all the 3 presentations have been extremely useful and inspiring for him.
हाँ, इसके साथ साथ मैं एक अकादमी का डायरेक्टर हूँ, सेक्स वर्कर अकादमी का डायरेक्टर हूँ, जो क्योंकि मुझे बहुत अच्छा लगा। यहाँ पे बहुत सारी बातें उठ के आई, जैसे कि कम्युनिटी मॉनिटरिंग हो या कम्युनिटी मॉनिटरिंग की बात हो रही है, और जो जैसे कि कैपेसिटी बिल्डिंग की बात हो रही है, कम्युनिटी लीड कैपेसिटी की बात हो रही है, और जो कम्युनिटी मोबिलाइजेशन को लेके बात हो रही है, बहुत अच्छा लग रहा है। और कम्युनिटी एनेबल इन्वॉल्वमेंट की बात हो रही है, तो ये सब मुझे बहुत अच्छा लगा, इसीलिए मैं 2 मिनट बात करना चाह रहा हूँ।
So along with me being a sex worker and a part of Ashoda Samiti, I'm also a director of Ashoda Academy, which is a sex workers academy imparting capacity building and conducting community-led research. He also said that he liked the discussions that has been happening. A lot has been talked about community leadership, capacity building, as well as also about the monitoring of the program. So he would like to take a few words. I know he would like to say a few words in this context.
पिछले 10 साल से हमने जो काम करते आए हुए हैं, ये सभी चीजों को लेके ही हमने कैपेसिटी बिल्ड किया है। कम्युनिटी टू कम्युनिटी कैपेसिटी बिल्ड बहुत जरूरी है, जो भी कार्यक्रम होगा उसके लिए जो बहुत इंपॉर्टेंट है, क्योंकि जब भी कम्युनिटी टू कम्युनिटी कैपेसिटी बिल्ड होगा, हम कम्युनिटी मोबिलाइजेशन हो या कोई भी जैसे कम्युनिटी लीडरशिप हो, ये सब कर पाएंगे। क्योंकि जब कम्युनिटी को जो वो ये दिखाएगा, मतलब अपना सिखाएगा, जब भी जाके वो आगे आएंगे और कम्युनिटी के जो प्रोग्राम सक्सेस करेंगे और सर्विसेज प्रोवाइड कर पाएंगे।
So what he is saying is that, while that a lot has been talked about capacity building, and he being the director of the Ashoda Academy, which has been building capacities in various countries over the last 10 years. So he felt that the need for community to community capacity building is very critical in this context, because only if the community to community capacity building happens, then the process of capacity building is fast tracked. And when the community to community capacity building happens, the mobilization happens further. And the other word he used is that, the community ownership to the program comes faster. And when these two are there, it automatically increases the service utilizations in the program.
और इसके साथ साथ जो जब हम लोग कम्युनिटी लीडर कम्युनिटी लीड करेंगे तो ये सिर्फ एक ही तरीके का नहीं होगा, दो तरीके का होगा। जैसे कि कहीं प्रोग्राम हो रहा है या नहीं, वहां पे कहीं प्रोग्राम ही नहीं है, वहां पे जाके जो कम्युनिटी का ये करके आइडेंटिफाई करके कम्युनिटी को ओनरशिप देके जब काम कराएंगे तो कम्युनिटी का प्रोग्राम आज सक्सेसफुली चलेगा। और दूसरी तरीके का ये है जैसे कि कहीं कोई एनजीओ है या कोई भी छोटा मोटा काम हो रहा है लेकिन कम्युनिटी को नहीं है, सिर्फ काम हो रहा है। जैसे कि अभी अलगा और बता रहे थे बहुत सारा कैपेसिटी ऐसा वो जो है कम्युनिटी क्यों लेके होता है, ये कम्युनिटी को दूसरे लोग करते हैं, लेकिन कम्युनिटी से कम्युनिटी जब होती है और कम्युनिटी के लोग जब उसको इन्वॉल्व करके करते हैं तो प्रोग्राम ये होता है। तो ये दो तरीके का कम्युनिटी लीड हमने पिछले 10 साल से जो 15 कंट्रियों में हमारा एक्सपीरियंस शेयर किया है, बहुत सारे कंट्री में जाके खुद हमने काम किया है, जैसे कि कहीं हफ्ते भर, महीने भर, कहीं साल भर। और इसके साथ साथ फॉलोअप सिस्टम भी हम करते हैं। पहले हम वहां को जाके ये करते हैं, जैसे आइडेंटिफाई करते हैं वहां पे क्या गैप है, उसको फिर कैसे फुलफिल करना, कम्युनिटी के बैक सपोर्ट रह के हम करते हैं।
Okay. So Akram has said that, this capacity building is not really, this community to community capacity building is not really templated, because when we go to a country or we go to a place, we sit there, we need to understand the local context and the situation, and therefore develop the plan accordingly. This happens on site. We go there, and depending on the need, we spend time there with the community, and we do not give the solutions. We actually sit there with the community and make them come forward with the solutions. And it is not a one-time activity. So once we started working with a group, we kind of keep them going, and then subsequently, there is a graded approach towards it. Other thing he also said is that, he gave some examples of different contexts. In a context where probably there is, it's more like a de novo situations where there is nothing. You go there and your approach has to be very different than where there is already some interventions going on, but you just need to strengthen it. So there are various situations like this, which, we have worked on, and we have realized that how things can be fast tracked to the community to community capacity building initiative.
लास्ट में और इसके साथ साथ जब कम्युनिटी को हम हैंड ओवर देंगे तो जब कम्युनिटी वो प्रोग्राम को लॉन्ग लाइफ लेके जाएगी, जब तक कम्युनिटी रहेगी वहां तक लेके जाएगी, ये हम सिखाते हैं। तो मेरा एक्सपीरियंस शेयर करने के लिए मुझे मौका मिला, तो मैं सबका धन्यवाद कहना चाहता हूँ।
And he also, the last thing he says, when there is real community to community capacity, when there is a capacity building of the community and the community is in the driver's seat in driving the program, that's when actually the program becomes sustainable, and that's what it will show a long-term impact. And this is what he has been seeing it over the last 15 years. And he said that, thanks for everybody for listening to me and giving me this opportunity to share my experience. Thank you.
Thank you so much, Akram and Sushena. And thanks for also reinforcing exactly what Kholi has been saying about community leadership and community capacity. I see, Kholi, you have unmuted yourself. Would you like to say something?
Oh, let me not disturb, rather to say something when we're about to close. Just give me a chance, only 2 seconds. When we're closing the session, it's fine.
Okay, that's okay then. I would then, looking at the time, hand over to Kerry Mangold, who is the director of the South to South Learning Network, to close the session and maybe give Kholi an opportunity as you close. Thank you.
Thank you so much, Parinita, and to the speakers. Colleagues, as we conclude this webinar, please allow me to express my gratitude to all of you for joining us here today. I think all and every contribution made to this session has been really engaging and informative, and valuable as we seek to share learnings on building strong foundations for scaling up impactful programs with key populations. This is particularly relevant given the new global aid strategy, which has a strong focus on key populations across all dimensions of services and rights and community-led responses. Today, we've heard from Richard about the importance and practicalities of intervention design for impact and management for scale and coverage. We then heard from Helgar on what have been core building blocks of a foundation for their national key population program. And Kholi then shared with us the story of the Sisonke sex worker movement in South Africa. The journey and initiative shared by Kholi showcases what a community-owned and a community-led response can look like within a broader country program. The South-South Learning Network really commits to continuing our role in supporting member countries to share learnings and jointly problem solve. And we would like to offer our support in facilitating any follow-up conversations or sessions around anything that you may have heard on this webinar today. So please kindly do reach out to us if there's anything specific that you would like to find out more from us. So perhaps let me end off, and Kholi, I'll then give you a last word. But in order to respond to the needs and improve our learning events, I would like to ask one last thing from participants before you leave the call. We have prepared a quick poll that I'm launching as we speak. There are just 4 questions in the poll. It's multiple choice. And we would love for you if you could answer this poll before you leave. In addition, if you have any parting thoughts on this session or any commitments or key takeaways that you have, I would also kindly ask that you please type this in the chat box before you leave. So Kholi, let me hand over to you so you can say what you like, and we will then officially close the webinar. So Kholi, yeah.
Thank you so much, Kerry, for giving this platform to Sisonke to share our journey. I was just wanting to pass my condolences to the Ashidaya Summit sex workers. I've learned about Dr. Parinita Janna, who passed away this year. I didn't know about that, so I was wanting to say condolences to all the sex workers in Ashidaya, and it is a loss to all of us because there's a lot that I've learned from him, and also the work that he has done in making sure that the services are led by sex workers in Ashidaya, and there's a lot of organizations that went and visited to go learn from the initiative that he has actually started with the sex workers. It's not only the loss of the Ashidaya sex workers, but it is the loss to all of us. So his legacy would continue. I was just wanting to say that, and also to ask if the presentations will be shared. It will be awesome because this has been actually a very educational space that it would be great to learn from other presentations. And thank you so much.
Thank you very much, Kholi. So just in terms of the administration and logistics, we will be sharing this recording as well as all the presentations within a week. We will also translate the presentations into Portuguese before sharing them. Colleagues, on this note, I would like to close the webinar. We will leave the line open for you to make any comments and answer the poll. And once you are done, you are welcome to drop off. And Parinita, thank you so much for facilitating such a very wonderful session with us today, and to all the speakers for their wonderful contributions. Signing off.